Thank you so much for this kind invitation and just on behalf of the ASLD, just welcoming us to your family. So really appreciate this. And then Dr. Hamad, I'm making this a very practical talk just for you. Okay. So the question just was that, how do we optimize nutrition in liver transplant candidates? And then I'll build on some of the thoughts from the previous speaker on this also. So the agenda is pretty simple. Thinking about malnutrition in the sense of liver disease related malnutrition and then complications, and even management from the cirrhosis related as well as chronic conditions. When we think about cirrhosis, we tend to think of this progression mainly driven by portal hypertension. There's chronic liver disease, compensated cirrhosis, decompensated cirrhosis, and then premature mortality. But as many of us, know in this room, I think we do need to expand the natural history. We do need to take into account the impact of hepatocellular carcinoma. We do need to increasingly think about chronic conditions such as diabetes, obesity, CVD as independent predictors of premature mortality. And then the third phase is that critical patient. Once they get to that acute on chronic liver failure phase with infection and kidney dysfunction driving outcomes. So when we think about cirrhosis as a multi-system disease, we need to sort of go beyond just portal hypertension as been historically taught and has been discussed, of course, during this meeting so far. Waitlist management is connected. We think about malnutrition, which I will talk about, but the other aspects are sarcopenia and frailty, which will be covered by the next speaker. Sarcopenia, we think in terms of age-related, and there in sarcopenia, we're talking about muscle mass as well as muscle quality. And frailty, we're talking about physical function. So this whole interaction of nutrition plus muscle quality plus physical function is important as highlighted by our guidelines, where this is associated at the bottom, as you see, with increased decompensation, more healthcare utilization, decreased health-related quality of life, death, and as well as adverse post-transplant outcomes. So we have to think of the whole spectrum when we think about management. Think about malnutrition as being driven by progression of liver disease and the interaction with sarcopenia as well as frailty. But besides that, we also need to think about cirrhosis complications and how they play a role with regards to critical illness, liver complications such as hepatic encephalopathy, and things that we do. An example was the Roux-en-Y gastric bypass. And so I'll comment a little bit about these additional drivers of malnutrition. An example is just having ascites. Think about the energy expenditure required to heat the fluid, patients having early satiety, so they cannot eat as much. Hepatic encephalopathy, patients, have unreliable oral intake. When things happen, they get readmitted. From an hyponatremia standpoint, we're asking our patients to restrict their fluid intake, but then again, the nutrition is restricted. And when patients are critically ill in the ICU, there's prolonged hospitalizations, and we keep patients NPO all the time at the time when they need the nutrition the most. Here's an example of just doing a low-salt diet. So I'll show you in the left figure is patients said, you need to be less than 2,000 milligrams per day in group A. And on the right was those with moderate sodium restriction. And what you see is that in group A, the patients that we said go on a low salt diet, there was a 20% reduction in calorie intake. So on one hand, we are emphasizing nutrition. On the other hand, when we say go for low salt, the nutrition is being held at least by 20%. So something for us to think about. What about the impact of chronic conditions on nutrition? A lot of the discussion over the last 2 days has been on diabetes and high blood pressure. Here's an example of an abstract presented, and I'll walk you through it. So what this shows on the x-axis is just different categories, all the way from masled without alcohol to the right with patients with alcohol liver disease. And each of the figures is the amount of chronic conditions. So the dark green is those patients that have both hypertension and diabetes, and the light green that don't have hypertension or diabetes. And what we see is that across the spectrum, where you're talking about MASLD, you're talking about MET-ALD, you're talking about ALD, if you have chronic conditions, that itself increases mortality. And one study that we looked at, and I will walk you through this, is we said, okay, you have a patient who has compensated cirrhosis, so that's the CC. You have a patient with decompensated cirrhosis, which is DC. And on top of that, you add the number of chronic conditions. So 0 to 1 to 2 to 3. And what you see is survival in the figure. The best survival, of course, is patients with chronic conditions and no comorbidities, which is on the top. But what you see here is DC0, which is decompensated cirrhosis, and compensated cirrhosis 3, which is a patient with chronic conditions. So what this shows is that if you have a patient with cirrhosis who has diabetes, high blood pressure, high cholesterol, their mortality is the same as having decompensated cirrhosis. And, we tend to not think about it that way, but the earlier we intervene on the nutritional aspect and comorbidities, the better our outcome. So in this case, we are proposing that having chronic conditions is a decompensation equivalence. And then if you combine both, you see that the survival is the worst when you have more of these chronic conditions. What about the impact of prior surgery? And this study of ours was highlighted in the previous talk. And what this showed is that if you had patients who had bariatric surgery as compared to no bariatric surgery pre-transplant, and we did intent to treat survival. So what happens to those patients after listing with or without transplant? And what we saw is that the survival was lower in patients who had had bariatric surgery. However, as was also mentioned earlier, is once you adjusted for nutrition status and skeletal muscle, this effect went away. So it wasn't the surgery itself, but it was the fact that these patients were malnourished as well as had sarcopenia that drove a lot of the mortality. So keeping that in mind, when we see our patients who've had Roux-en-Y gastric surgery, sleeve gastrectomy, we do not see the same kind of effect. So what about interventions? So when we think about interventions, what is the thing that really helps our patients? I think with all of us, whether we try to lose weight, do more exercise, it's about structure and accountability. So we can have all the interventions we talk about, but if we don't have some kind of framework to put it together, it fails. So one of the most successful things I would say in pre-transplant management of nutrition and frailty has been establishing something like a prehabilitation program. And it doesn't have to have the same components, but the point being is that you have a group of patients who are being held accountable by a team who are mainly just looking at the nutrition standpoint and frailty standpoint, and the impact of dietitian is crucial. And the role of any prehabilitation team, and we've had experience with this also as well as other centers, is assess in a standard tool, intervene, and really hold patients accountable to going up on the calories, and then reassess, follow up, and see if we need escalation of therapy. So assessment, intervention, reassessment, and keeping the patients help accountable along with families to help them meet their nutritional goals. And when we think about nutritional goals, these are the 6 components that may drive improvement from a nutrition standpoint: caloric needs, protein, carb and fat intake, supplementation, glycemic control, and then cirrhosis complication management. And I will go over these in detail. So one is energy intake and protein. There's several recommendations by different societies, but I would say similarities are as follows. Energy intake, about 35 kilocalories per kilogram per day for our patients. For BMI less than 30, basing calculations on dry weight or ideal body weight. And the protein intake is about 1.2 to 1.5 grams per kilogram per day. Or in the critically ill, this target is higher. And the biggest message, of course, being even for the primary care audience, is to know there's no role of protein restriction because you sort of need it for the muscles. And again, the different societies have different nuances, but the intent is most sort of talk about this kind of protein goal of about 1.2 to 1.5 grams per kilogram per day. The pattern of oral intake also matters. What we want to avoid is prolonged fasting. So small meals every 3 to 4 hours with about 20 to 30 grams of protein per meal. And, especially in the US diet is a very carbohydrate heavy diet. We cannot expect patients to change everything overnight. So we say, okay, start off with at least one meal, which is carb heavy, that you replace with a protein heavy meal. Animal and proteins both are needed. The exact ratio is unknown, maybe 60-40. And then in addition to that, having high protein nutrition supplement. And what is a high protein nutrition supplement? If you read the labels, if more than 20% of the energy comes from protein, that would be a high protein supplement. And then more and more, we're seeing this importance of this late night evening snack, carbs plus protein, to just cut down that accelerated starving that happens overnight. And the recommendations are about 50 grams of complex carbs and 20 grams of protein. And then the carb recommendations given right there. One amazing resource, if you have not checked out, is this website called cirrhosiscare.ca for Canada, which has a lot of patient information, not just on nutrition, but a lot of cirrhosis management. And we often use handouts from this website for patient education at our center. Fifth is management of chronic conditions. And that's the debate that comes in the obese patients that was highlighted before, is what do? You have somebody with a BMI of 40 and we say, okay, lose weight. At the same time, as the weight loss is happening, they're losing lean mass. And therefore, that struggle on the waiting list is real. And I don't know if we can just say lose weight at that time. One, it's hard to get an agent such as GLP-1 in decompensated cirrhosis. But the thing we worry about more is the lean mass, as even, Mazen pointed out yesterday, in his talk. The importance of glycemic control becomes important. And then keeping in mind that history of malabsorptive surgery. Especially the weight reduction, malabsorptive rather than the restrictive. Now, talking about critical illness. So on the other spectrum, all those things help if you have time. But what if you don't have time? And the question becomes what is the role of going from PO to enteral, putting an NG tube and then feeding that way? So here's a recent randomized control study that was done, which randomized patients to just getting high protein as compared to high protein plus nocturnal feeds. And this may be helpful for helping with living donors. So just getting the supplementation also at night. And what we saw, and the intervention is in the dotted line, is that the patients that got a combination of not just the high protein, but also nocturnal feeds for the severe malnourished, the weight increased by 10 kilograms. Second thing is the resting metabolic rate also, stayed, most patients stayed higher, which is this middle figure. And then the third part was the total protein intake also met that target of 1.5 grams per kilogram. So it was helpful as a bridge. So this may be something that maybe we should consider in patients that we can time it for living donor liver transplantation. And then the final part is the consideration of the cirrhosis complications. Just as I mentioned earlier, we're saying patients to restrict free water, but to remind them that don't restrict the oral supplements. Consider protein bars versus drinks if you're trying to really cut down the amount of fluid. And then consider nutrition-dense enteral formulas. Micronutrients play a role. We often check this in our patients. The one that I would highlight is just the vitamin D, and the supplementation has been given there. Something that I'm recognizing more and more is exocrine pancreatic insufficiency, especially in our alcohol patients. We have not done this consistently, but I would love to hear the experience if people do this. Your patients have these symptoms of, steatorrhea, having the weight loss, and weight loss, of course, happens. Checking a fecal elastase, and if that's elevated, considering just lipase supplementation with meals. So this is one more thing that I think we can consider. And then the last part is other supplementation, omega-3, maybe some benefit, branch chain amino acids, we've been used for hepatic encephalopathy, and that was mentioned in the previous talk. The problem becomes is that patients really cannot tolerate this often and discontinue it. Testosterone, Dr. Tapper did a study looking at a large data set and seemed like, testosterone supplementation helped. But that again, was just, a retrospective study. But I don't think, we have solid data just in decompensated cirrhosis. And finally, even specific amino acids, I don't know if they have a role in this population. So the key takeaways, I think, as I just mentioned earlier, I think the biggest thing is having, really focused goals for our patients and holding them accountable. And I think one best way to do that is just having a structured program. Everybody's busy in their practice, but if part of your transplant program can be dedicated to have a prehabilitation clinic, I think that may help. Thank you so much.